I am going live to talk about a brand new article. Oh, my light is turning off. A brand new article that just came out, and I'm going to try to fix this light here. So sorry. A brand new article that just came out on Rehab for functional neurologic disorders, and it's perfect timing because it's functional neurologic disorders awareness month, and I'm having technical difficulties here. Let me see if I can fix this. Something in my lighting is a little temperamental. We'll see if this works. So anyway, we're going to talk about functional neurologic disorders. We're going to talk about rehab. And if I haven't met you yet, my name is Julie Hirschberg. I am from Reactive. Team Neuro is what this is. I am a neurologic physical therapist, the owner and founder of Reactive Therapy and Wellness. I'm in the Los Angeles area, and I love to hear questions from you all. And another thing that I love is I have a couple of very dear friends who are neurologic physical therapists on the East Coast in Boston, and we chat all of the time. And on Easter morning, on Sunday morning at 6 a.m., I got a text from Heather, and it was like, oh, look, there's a new article out. And we had just met the previous week. We are working on some of our own publications and presentations, which I'm really excited about. So I was like, awesome. You have to love when you have clinician friends that send you brand new articles. So then I read the article and said, oh my goodness, we've got to talk about this article. It is called Routine Outcomes and Evaluation of an 8-Week Outpatient Multidisciplinary Rehabilitative Therapy Program for Functional Neurologic Disorder. It came out, I think, online. It actually published in December of 2023, but in the actual Journal of Neurology in 2024. First author is Lisette Guy, and it's from a group that is out of South London. They run a program called FIND, F-I-N-D, at the Bethlehem Royal Hospital in South London. So there's not a lot of research out there on rehab and FND. So it's always exciting when something comes out. And thank you again, Heather, for sending this to me. And oh, hello. Hi from Oxford, UK. Well, this is from your time zone, at least closer to your time zone, this particular article. So let me tell you a little bit about the background and what they did. So they run a specific FND program, by the way, and it's called FIND, which I love. That's a great name. And it's an 8-week outpatient program that includes physical therapy and psychology twice a week for 8 weeks. So 16 visits of each. And then they have some really, I think, innovative and interesting things that they do. They do some group sessions. They do education. They bring in alumni from the program. They have a family day or a friends and family day. Just a lot of cool things that are a part of this program. And it's an ongoing program, which, by the way, I haven't contacted the author. The corresponding author is Susanna Pick. Her email is on the publication. I should reach out to her because I feel like all of the time folks from the UK are asking about places to go. This sounds like a great place. I don't know for sure that this program is ongoing, but if it is, I think it would be a good option for people. So they looked at their... Oh, hi, Denise. Thank you for joining. They looked retrospectively at their program, meaning they took a couple of years of data. They were collecting regular data, which kudos to them for collecting regular data. And then they're sharing that data with us. So this is not a randomized controlled trial of some people did this and some people did this, and let's compare them. That's the gold standard when it comes to evidence-based practice. But this is a really great way to get some data. And basically, they're telling us, here's what we did, and here are the outcomes. So, as always, when we look at an article, we want to know who are the participants, because maybe this sounds like people like yourself or like the clients that you see, but or maybe it doesn't. So the participants were people that were referred to the program, and they actually had criteria. So one, that the person had FND, great. That the person accepted the FND diagnosis, that they were able to travel to and from the program, that they would strive to be there 100% of the time, even if the symptoms make this difficult. And that can be really hard, right? So if you have ebb and flow of symptoms, you don't know for sure that you can make it all the time. So this is asking for a person to kind of sit down, reflect, and agree, like, I am really committed and I'm going to make it to these appointments. For some people that I know and I meet with FND, they're not at that place. They can't get there yet. So if that's you, then maybe you wouldn't be able to do 8 weeks of twice a week of a program. So they had no outstanding diagnostic or medical investigation. So this is one of the number one questions I get from clinicians is, what do you do with a person who is still going through tons of testing, going down a lot of different diagnostic investigations? It can be really hard for that person to do all of that testing and do a lot of treatment at the same time. And it can be really hard for that person to start treatment when there's so many unknowns. Like, what do I really have? What is my diagnosis? Is there something else going on? And what you'll see in some of the other rehab studies, honestly, is that they exclude people that don't have the confirmed diagnosis or that they're going down some other investigations, because it frankly just makes treatment really challenging for a person. So when people ask me that, I said, hey, like, it's okay for somebody to wait to start rehab when they're still undergoing investigations. That's totally fine. So again, I think that's a person-specific consideration. So here are the other pieces. Patient consents to medication review, meaning they would look at their medications. Here's one that I'm going to just be really honest, I don't agree with. This was number 5. Patient consents to reduce reliance on aids and adaptations. So I don't think we should do that in FND. In fact, if people need aids or adaptations to make it into the world and to live their full life, then we should actually support and find those aids and adaptations that they might need. I'm not sure which aids and adaptations they were talking about, but a lot of things my people need, I don't own them, I'm so sorry. The people that I see and work with and that come to Re+active, they might need an assistive device. They might need a wheelchair. They might need noise canceling headphones because they're very sensitive to different sounds. Those are adaptations that person might need because of the way their brain works, because of their sensory system, because of their sensory processing. So I disagree with that part of this program. That's okay. Doesn't mean it's a bad program. Doesn't mean anything about it, but it's actually a little bit of a myth. And it's in the old consensus guidelines, which we need new consensus guidelines, but in the old consensus guidelines, they did recommend to not use devices or aids for a person. And I disagree. I don't think that's very helpful for people. So back to this list. Medication review, they agreed that they won't use emergency services for identified functional symptoms, that they can transfer independently. So this is important. This was not a program that was for a person that might need assistance for transferring in and out of a car, that they can attend to all their self-care needs. So again, they're independent. They're not actively in a psychotic state or not actively suicidal. So I actually really love, they made a table of these. It's table 1 in the article, which, by the way, I'll send the link out in our newsletter this week. If you're not on our newsletter, comment newsletter on our post earlier today, and I'll send you the link for that. But it comes out every week with these videos and all the links and stuff. So I like that they put this in a table, really easy for me to see and screen. Who were they studying? It was a small group of people that would be appropriate for this. And in fact, they had, I want to give you the number breakdown. I think they did a really great job of breaking this down. They had 136 people referred to the program, 115 that were assessed to see if they meet those criteria, and only 53 met that criteria. So half of the people did not meet the criteria. That's a lot of people not served by this program. I'm kind of curious where those people went, to be honest. Because they still really need care. So I'm very curious. 50 attended the program and 45 people completed the program. So that's a pretty good number that they're looking at 45 people and their data. I know for our program at Reactive, we have hundreds of people that have completed our FND program, and we do have data on a good half of those as well. So actually, as I was reading this, I was like, we should publish this. This would be really helpful, so we could tell you what we did. So again, the article, I see a few questions here, so let me just go in here. You should franchise and come to England. Oh my gosh. Okay, that's a really lovely compliment. You should franchise and come to England and show them how it's done. I also love that name. I will walk 500 miles. Somebody else said, you're great. Gosh, you're like really making me kind of blush. So thank you. So let's talk about what they did though, because again, I think did some pretty cool things in their program overall. So their program was 8 weeks, so a couple of months, twice a week for the physical therapy, twice a week for psychology. And then they did 3 group education sessions, they did PT workshops, and they did some mindfulness practices. I love that. Somebody is asking, by the way, if I have a link to the article. I will put this in our newsletter. It is free, full text, so you can download it, and it's called Routine Outcomes and Evaluation of an 8-Week Outpatient Multidisciplinary Rehabilitative Therapy Program for Functional Neurologic Disorders. We really struggle with getting concise in the names of our articles, right? Like, I have a hard time saying that all out loud. It was a lot. So, okay, so let's get back. So they did PT. This is how they described it. Task-based, which is great. That's based on function, and it's externally focused when it's based on a task. They worked collaboratively to set goals. I love that. They're diverting attention from symptoms and to an external focus. So actually they don't say external focus. That was my word. That's my optimal language, but task-based or cognitive activities. They also had education sessions about pain and exercise and graded exercise and pacing. I think that sounds pretty great. That is, if I compare that to what we do at physical therapy at Reactive and some of what the best practices are with FND, it sounds a lot like that. I think the pieces that maybe are missing would be attunement to sensory, autonomic, lifestyle, and physical impairments. Yes, those are 4 pieces of the pie, but it's a very good start. I think it's a very good start. In psychology, so they were primarily doing cognitive behavioral therapy. I've talked about this before. CBT has some great merits in the world of neurology. It's very easy to study because you can kind of handbook it and make a protocol. In fact, they use the 5 areas approach. I've got that book over on my bookshelf over there, which is a nice intro to how you might use CBT and FND. But I think it's limited. And even the research in CBT and FND, there's some benefit, but not for everybody, and it might not really be the most helpful thing. Now, here's what they described, though. It sounds like they added in other components. It wasn't a purely protocolized psychology effort. They considered individual predisposing or precipitating factors. They had people keep diaries. And then they mentioned the themes of their psychology sessions, anxiety responses, changing their activities so that they might not be avoiding some of their favorite activities. These are not their words. I'm putting my own words into this because they say challenging avoidant behaviors. And I'm going to say that's actually looking for engaging in those things that you love. But that's because I don't really appreciate the negative language. I understand you have to write it in a research paper. But graded exposure, a lot of education, grounding, and goal-directed activity. That actually sounds really great. So you've got these two pieces, PT and psychology. Clearly missing is occupational therapy. It is OT therapy month, by the way. And I absolutely would not do an FND program without OT. Maybe they don't have OT here as part of their program, but I think they should. That would be my opinion. And then a lot of self-management. So how to get back to activities without overdoing it, for example. Really great stuff in this program. So not surprising that people get better. So they measured everything from functional measures like a timed up and go or 10-meter walk or Berg balance scale to anxiety measures to getting back to work and social activities. So they measured all of those routinely with their patients, which is great. And then they gave the results. So everybody improved. No, let me take that back. On average, people improved. I shouldn't have said everybody improved. On average, people improved on everything. Anxiety, depression, getting work and social activities, the 10-meter walk, the timed up and go. They just did not improve in a statistically significant way on the Berg balance scale. But everything else was I can't say that word very well. Statistically significant. Oh my gosh, that's so hard to say. The other thing that I think would be important is to give you a little bit of the people that actually were involved in the study. They were on average 40 years old, but it ranged from 16 to 61. So I love to see that they had teens in this study. The symptom duration was an average of 4.74 years. So people had symptoms for a long time, but it ranged from part of a year to 21 years of symptoms. So this is why you want to look at all of the data in a research article, and why sometimes just like a one-liner about an article is not enough, because this is telling me this was effective for people who maybe had this for a long time. The other thing that's really nice is they created a table of what types of symptoms people had. Weakness was a predominant symptom. There were sensory symptoms, fatigue, pain, headache, dizziness, not as common in this group, tremor, not as common. So a lot of motor and sensory symptoms in this group. I'd be really curious about what they did for the sensory system. You know me and my obsession with that. So bottom line though is people got better. They also measured them. So they measured them at the beginning and at the end of 8 weeks and 3 months later. And they also maintained that improvement. So that's fantastic. I think that's really fantastic. Some of the things that they brought up in the discussion were that they classified people in some of the anxiety scales at baseline and then 3-month follow-up. And most people were classified as severely impaired, functionally impaired, severely depressed, severely anxious, and a lot less people were in that severe category at the end. I think that's a great outcome of this type of intervention. Really good. The things that they said were limitations or really mirror what I would say are limitations too, is that this was a small group of people with functional neurologic disorders. It didn't include everybody. And it didn't include all disciplines. So it was multidisciplinary. So it had PT and psychology. I was very curious. I don't see this explained here, but I don't think it's transdisciplinary or interdisciplinary, meaning I don't hear that psychology and physical therapy are talking to each other. That, I think, is the secret sauce of rehab, is when your team is actually talking to each other and figuring things out together. Maybe they had that, maybe they did grand rounds or something, but they didn't include that in the description of the study. I think people would have even gotten better. That's my opinion. But the thing is, they got better, and they got better with 16 sessions of PT and 16 sessions of psychology. And I think there is a lot of opportunity here. Number one, how does this inform us, right? How does this inform us for what we do? One, I think great, rehab is helpful in FND. I mean, we kind of already knew that. That is exactly what our team is doing on a day-to-day basis, is neurologic rehabilitation. It's effective and helpful in FND. Now, this wasn't a randomized controlled trial, so to really look at the effectiveness, we would look at a group of people. Let's get 40, 50 people that didn't do rehab and the 40 or 50 people that did, and then really compare those two, right, to really know if rehab is effective. But at least from this retrospective study, these folks got better. That is good to know. What people should be getting after their diagnosis is immediately referred to neurologic rehab. I know because I talked to a bunch of folks. In fact, in our FND membership that we're running, I'm talking to people all the time, and they're not referred to rehab. In fact, they might be told that they're faking it and they should just go home, which is absolutely ridiculous. So one thing that I hope, as more studies are done in the realm of rehab, is that more people are referred. Not just to any rehab, by the way, but to neurologic rehab. And not even just to any neurologic rehab, but to an FND program. I think what's so nice, so again, this was called the FIND program, and it was at, let me get the hospital right here, Bethlehem Royal Hospital, South London and Maudsley, I think. There are other FND programs, right? So this is just one. Reactive is one. There are other FND specific rehab programs, and they are very effective and helpful for people with FND. What we need is to ensure that neurologists know about these programs and that they can refer people so that people can get that type of care. I'm going to answer questions here. I just saw a couple have come in, so I'm just going to scroll down. Sunbeams and barefoot. Oh, I wish you were in Alberta, Canada. Doctors still look at me like I made some random name disorder. Trying to educate them is so hard and so frustrating. You shouldn't have to educate doctors about your diagnosis, but I know that commonly happens. So I hope you have some great resources for that. I personally love the resource from FND Action. They have a Inform the Doctor campaign, and it's a PDF that you can download, and it's got great information to give a doctor about FND. But I want to tell you, some beams and barefoot, if you're not already, you should get in our FND membership. So our FND membership is a membership for people with FND. We do education classes every week, which, by the way, I thought it was cool that they include education classes in this program that I just reviewed. Education classes every week. We have a support group once a month. We have exercise and activity classes. And in fact, we have a dysautonomia class starting this week. It's starting on Wednesday. I'm so excited for people to do graded exercise or graded activity in this class. So anyway, it's a membership, and our whole team is in the membership with you. We lead the classes. And in fact, if people are an annual member, we do a wellness evaluation every 6 months. I've been doing those, so I get to meet with all these wonderful people. So anyway, I'm just telling you that in Alberta, Canada, actually from anywhere in the world, you can join that FND membership. And we can work with people internationally now with PT and OT. So if you wanted to work with us on telehealth, you can. So I just wanted to share that with you. And to my clinicians who are here and still testing the waters with FND, still feeling like you're starting to get the basics but not quite sure, or you want to know where to start, we are doing a boot camp, our very first boot camp. It's an FND boot camp. It's for clinicians. We're going to spend a week together learning and practicing. We're going to do motor control, sensory, autonomic, and we are going to review, give some really specific action steps, and then you're going to go practice. Then you're going to come back because we'll have a group where you can share what you did and get some feedback on it. So I'm super excited. We've been thinking about this for a long time, and it literally, the doors open for this boot camp tomorrow. So again, this is for all the clinicians out there. If you've been wanting to learn and grow with our team, basically, and to learn more about FND, join this boot camp. So again, our doors open tomorrow. So we'll be announcing it. You will see it. It will be really easy to find. But I wanted to tell you because I'm so excited. It's FND Awareness Month. We are going to literally be talking about FND every day. We are going to try to change the world for people with FND. And I know there are so many clinicians out there that want to help people and just don't have all the resources. So we're going to help you out. So join us for that. I see a couple of other things. What are your recommendations for pacing exercises to avoid burnout? Now, I think you are asking this, and I might have you clarify, because I got to tell you, I have to do a lot to avoid burnout myself as a clinician, but I think maybe you're asking this from a patient perspective. So this is a very person-specific question. And there aren't necessarily pacing exercises, but I will tell you one thing I advocate for anybody who's experiencing a lot of up and down of symptoms and might do activity or exercise and then be like in bed for 2 days after, or have post-exertional malaise, they really might need to have their autonomic nervous system assessed. Look at heart rate, look at blood pressure, look at response to changes in position and exercise, and maybe not even exercise, just basic activities, so that they don't overwhelm their nervous system, particularly autonomically or cardiovascularly, and have a very specific level of heart rate or exertion that they do, and then build it up in a very slow manner. So I wish I could be like, do this exercise and you got it. It just doesn't work that way. Everybody's nervous system is so different. So this is why we're adding a dysautonomia class to our membership, and it's literally starts this week, because we're going to actually do a lot of education on how do you monitor this for yourself and how can you progress slowly but systematically and confidently through. Now, the other thing I would say is get OT. So OT, occupational therapy, is so fantastic for truly helping a person understand their life, their nervous system, their roles, and what they have to do during the day, and helping to figure out what's the right pace for you. I highly recommend OT. Somebody else asked, do you have suggestions for learning about graded exercises? This seems to be a sticking point with our patient. So I feel like I just talked about this too. Suggestions for learning about graded exercise. So, but maybe you're talking about it in a couple of different ways. So graded exercise could be anything from like graded aerobic exercise, or just getting back to leaving the house, like a graded activity tolerance, right? So I do want to make the disclaimer, graded exercise, not for everybody. If somebody has a very low tolerance for exercise and activity, very likely a graded exercise protocol is not appropriate for them. And they may need like what I would call a pre-protocol, a pre-build-up of graded exercise. So what I would say, well, for number one, you know what is a great resource? Re+active and our Brain Bites membership. So our reactive team, we talk about this all the time. We mentor and educate other clinicians about this all the time. Largely in the autonomic nervous system that we're talking about this. And in fact, we open up our Brain Bites doors in just a few weeks, actually. I'm super excited about that. And in May, we have an amazing person, Emily Rich. She's an OT. She's coming to talk to us all about the autonomic nervous system and some of the graded activities. So you're right. It is absolutely a sticking point for a patient. I'm going to think if we've already released some of our resources on this so that you could get started. But otherwise, come join us in our boot camp. Come join us for Brain Bites. This is the kind of stuff we talk about all of the time. Really great question. Yes, patient perspective. Great. That's what I assume. How do you ask to have your autonomic nervous system checked? That's a great question. So I would start with your neurologist. Typically, autonomic testing is done with a cardiologist. But now my caveat is not all of them are looking at autonomic dysregulation like of the sorts we might see with POTS or postural orthostatic tachycardic syndrome. But that would be the place to start. If you have a physical therapist, they also can do the screening. Now, they don't do the diagnostic testing, but they can screen. So screening with things like the active stand test or a Buffalo treadmill or Buffalo bike or Buffalo stepping test, that is a lower level exercise tolerance test that can be done for a person to look at which heart rate symptoms might occur. This type of testing, by the way, really comes out of the concussion world and in the autonomic world, and we have been using it in many populations for a long time. But I would ask first if somebody would do an active stand test or a tilt table test is what they might do. And to do some sort of exercise or activity tolerance test. Now, the exercise or activity tolerance is not appropriate for everyone. So particularly if you have myalgic encephalitis or chronic fatigue syndrome, no, I wouldn't be doing that test. We would be doing the modified version of just looking at your heart rate response with your everyday activities. Great question. Awesome. You are welcome. I love your questions. Suggestions on lowering the heart rate. Yeah, so you need testing. If anybody is telling me my watch, by the way, my watch is not the perfect monitor, but hey, we'll take it. When someone says, like this person is sharing, my watch says I'll go from 80 beats per minute to 121 while I'm just standing in the kitchen. And I'm a very active person. So first I'm going to tell you, it's not that you're out of shape. Okay. So that's not why. But this is a sign of some autonomic dysregulation. The autonomic nervous system, by the way, is that part of your nervous system that controls your heart rate, controls your blood pressure. It controls all of the automatic things happening inside our body. How our food digests and so many awesome things, really. So it might be dysregulated. It's very, very common in functional neurologic disorders. And look, you're already kind of screening it yourself. So this, I would bring this right to a physical therapist, because you know what? There are many things that you can do for this. And again, I'm going to be like, come to our FND membership. We start our class on this on Wednesday, and it's going to be really helpful for you. So, but this, I think you want to work individually with a physical therapist on there. There's a lot that you can do to help manage that. Really great question. Okay, heart rate test for 24 hours. That's a great start. That's an excellent start. Then, and this person says also don't have a neurologist or PT, then I'd ask for those referrals. Great question. If a patient doesn't have physical symptoms ongoing and they only arise during PNES, so PNES, by the way, not a term I use, but psychogenic non-epileptic seizures. I would use the term functional seizures, but PNES is largely used in the literature and the medical field. If physical symptoms ongoing, they only arise during the seizures, do they need physical therapy as well? I'm going to tell you, Susan, great question. And absolutely they do. Because, so if somebody has functional seizures, they typically come and go, and the person might come into physical therapy and be totally fine on the surface. But if you dive deep into their sensory system and autonomic nervous system, I guarantee there is something there that is contributing to the functional seizure. And it just hasn't been tested. So this is why I love physical therapy, occupational therapy, and psychology working together to figure that out. The sensory and autonomic pieces of the pie are typically the biggest in those intermittent components. And without physical therapy, you would never be able to do graded exercise, for example, for a person with autonomic dysfunction. So absolutely test those autonomic, sensory, but all of the pieces, you're going to discover something that is awry. I guarantee it. We always do. Now, I didn't always know that, and I didn't always do it. But now I know better and do better. So there you go. Awesome questions from you all. Again, if you're not on our newsletter, be sure to comment newsletter. I'll send you the links. This will be an article, and this video will go right out in our newsletter every Friday for clinicians, every Monday for patients. And this article, again, routine outcomes and evaluation of an 8-week outpatient multidisciplinary rehabilitative therapy program for functional neurologic disorder. And guess what? Rehab is helpful for FND. So good. So I'm going to log off here. Thank you so much for joining me today, and I will see you next week.